Hello and welcome to SR Academy. So knowing about the cervical pedicle screw is important in few cases where we need a rigid fixation. So coming to the evolution, it started off with the conservative management of all cervical spine pathologies, which includes traction and external orthosis. Later on, the surgical management has come into picture. Started off with interspinous wiring, and then lateral mass screws and cervical pedicle screws became the basis for rigid fixation in cervical spine pathologies. So the first cervical pedicle screw was introduced by Leconte in C2 for hangman's fracture, and the first subaxial cervical spine pedicle screw was introduced by Abumi. So considering interspinous wiring, there is no stability in extension, rotation, or lateral bending. In lateral mass screws, which are more stable construct, but it has a small bony purchase with less pull-out strength, especially in osteoporotic patients. So if you're correcting any deformities, this hold of lateral mass screws is not sufficient to get a good correction. So the cervical pedicle screw helps in this way by having a rigid construct with a greater pull-out strength, and it also restricts the number of levels of stabilization. However, improper technique can lead to catastrophic iatrogenic complications. So talking about the biomechanical strength, there are few studies which show the significant strength of cervical pedicle screw compared to lateral mass screws. So the strength of the cervical pedicle screw depends on the width of the screw rather than the length of the screw. So always measure your screw by measuring the outer pedicular height or outer pedicular width of the pedicle, measuring in CT preoperatively. The indications being trauma, tumor, degenerative, and especially in unstable spine and rigid deformities to be corrected, the cervical pedicle screw can be the choice of fixation. Coming to the anatomy of pedicle screw, the medial wall of the cervical pedicle screw is way thicker than the lateral wall. So there are several chances of violating the lateral wall than the medial wall. So when you all reach the lateral wall, there are high chances of injuring the vertebral artery. The factors contributing to the vertebral artery injury are anatomical variations and surgical techniques. In anatomical variation, the V anomaly or the narrowed pedicle screw has a high chance to injure the vertebral artery. So always be cautious of the anatomical variation. So preoperative evaluation of the patient with the proper CT and CT angio is really important if you are considering to put a cervical pedicle screw. So starting off with the entry point for the cervical pedicle screw is 1 mm inferior to the facet and 2 mm medial to the lateral notch. At C2, the level of the entry point is below the lateral notch. From C3 to C6, it's at the level of the lateral notch, and at C7, it is above the level of the lateral notch. This is the facet joint, and that's the lateral notch of the lateral mass. Your entry point is 1 mm inferior to the facet and 2 mm medial to the lateral notch. The direction of the screw has to be as medial as possible so as to prevent the lateral cortical breach. Sagittal direction of the pedicle screw from C3 to C4 is superior, and from C5 to C7 it is inferiorly directed. The patient is positioned in prone along with the head fixed with Sujita frame, and the shoulders are strapped and pulled so that in C-arm, before exposure, make sure that cervical spine is visible so that it will be easy for you to have a proper trajectory guidance when you're putting the pedicle screw intraoperatively. So always have a proper neurophysiologist with the neuromonitoring to give the proper feedback while you're operating. In lateral mass, the surgeon always stands side by while putting the lateral mass screws. But in cervical pedicle screw, it is always better for a surgeon to stand on the head and side to put a cervical pedicle screw, and it will be easy for him to put in that direction. And the C-arm has to come from behind the surgeon. The step one includes the pedicle probing. You have a proper gear shift so that the entry will be easy for you. So take a proper probe when you're putting an entry. Once the entry is made, you look for the integrity of all four walls, and once the integrity is secured, then go for tapping. So make sure when you're tapping, there are high chances of breaching the lateral pedicles wall when you're removing the tap. So always remove the tap in the same angulation of introducing the tap. Once the tapping is done, the wall's integrity has to be checked with the pedicle sounder. Once the wall integrity is confirmed, then gently introduce the screw in the same trajectory made by the surgeon before introducing the screw. So this is the post-operative C-arm images of the cervical pedicle screw. And you should always remember the risk associated with cervical pedicle screw before considering it for your cases. So always have a safety options before introducing the cervical pedicle screw. So always keep it as a reserve only for few cases of high, very unstable cases, or if you're correcting a deformity like Henke's pond, you try to correct the drop head so that he'll have a proper gaze. In such instances, you need a good rigid fixation. So in those cases, you always try to implement a cervical pedicle screw fixation than the lateral mass screws. So before introducing the screw, you always opt for the safety techniques so that you don't have any complications while you're doing the technique. So the basic and the first most thing is fluoroscopic guidance. And the second technique is the cortical drilling of the entry point, which is also called as Abumi's technique, which helps in direct observation of the pedicle as well as it improves the range of trajectory while introducing the pedicle screw. So the other safety technique is laminoforaminectomy. Whenever the surgeon is not confident of the trajectory of the pedicle, you always go for the laminoforaminectomy, which gives the visual as well as the tactile feedback. You always palpate the pedicle and try to direct your pedicle probe in the way of the pedicle by direct visualization and the tactile feedback. In instances where there is a severe cervical myelopathy and the surgeon is opted for the cervical pedicle screw, it is always better to do the decompression first, because sometimes whenever you put the pedicle screw, there's a high movement of the C spine, which will further damage the already compromised cord. So it's always better to do the decompression first, then go ahead with the cervical pedicle screw fixations. So ultrasound transducer is another method to check for the cervical pedicle screw integrity. And navigation and 3D guided techniques are the further advances which helps in securing the safety standards of the technique. So the complications include the most catastrophic vertebral artery injury. So always have the CT angio done before going ahead with the technique. So whenever you are doing the cervical pedicle screw, by chance if you injure one side, so always opt for the lateral mass screw fixation on the other side. But if at all you have seen a dominant and the non-dominant VA on your CT angio, always go ahead with the cervical pedicle screw on the non-dominant side, and on the dominant side try to do the lateral mass screw fixation and have a safety and secure your dominant VA. So always opt for the lateral mass screws on the opposite side. Neurological injury, though rare, can happen. The rarity is because of the thick medial wall. Sometimes in a narrowed pedicle of the cervical spine, there are chances where you can even breach the medial wall and injure the neural structures. So in that instance, always it's better to do a laminoforaminectomy and put your dissector on the pedicle so that it will not breach the medial wall while you're introducing the pedicle screws. So in narrowed pedicle screw, sometimes over manipulation of the pedicle might lead to pedicle fractures. And infection can be seen in any of the surgical cases which are done at the cervical spine level. And to conclude, the cervical pedicle screw fixation is the most rigid construct. The advantages being less level of fusion, and you can do all posterior approach in an unstable spine where 360-degree fusion is necessary. The decrease in complication rates associated with cervical pedicle screw incision can be achieved by proper surgical techniques with the technological advancements. Thank you.